at the end of the series, I think today's is the last, isn't it? For this series on psychotherapy. Are you planning to take feedback from participants?
You can take, madam.
Yeah.
We'll create a Google form and we'll circulate it.
Yeah. I mean, about the entire series, you know.
Yes, madam. And based on that, also we're planning whether they want some more series, some more topics, and then we'll decide after a couple of gap of 2 or 3 weeks, madam.
Yeah.
Because if I take it, I think it comes in the way. Okay.
Srikala, madam, you can press print screen on your laptop.
Oh, yeah. That's a better thing. He says print screen.
Yeah.
Function? Where is it?
In the top rows, it will be, madam.
After F12.
F12.
Wait a minute. You are in the view, Bharath. Okay. Okay. I'll just copy because I think they are. Okay, fine. Okay. What's your usual, do you think that 27 people have come, Vishwas?
Usually it goes up to 50, madam. After 30, we'll start, madam, usually.
Okay.
Once we reach 30, we'll start, and in between they will come and join.
I think we have a quorum.
Yes.
Shall we start, sir?
Yes. Yes, Bheem.
Good evening, everyone. Warm welcome to this session on the second part of psychodynamic psychotherapy as a part of IPS-KC webinar series, which runs as a primer for postgraduate students on psychotherapy. It's and today we have Professor Dr. Ahalya Raguram. After a very interesting session last week, we are very eager to go into the actual psychodynamics psychotherapy, its theoretical aspects and its practical aspects. So very warm welcome to all of you. I request Dr. Somshekhar Bijjal, Honorary Secretary IPS-KC, to give opening remarks.
Good evening to one and all. On behalf of Indian Psychiatry Society Karnataka chapter, I would like to welcome all of you for this psychotherapy primer series. As I mentioned in all the previous lecture series, that since last year we started this webinar series for the benefit of the postgraduate student as well as the practicing psychiatrists and other mental health professionals. So We have covered many. This last year we missed this psychotherapy related series. Hence we started this year with the psychotherapy series only. And so far we have conducted around 6 webinar series, which included CBT, then the behavioral therapies, motivation and enhancement therapies, and many other DBT and all. And this is the second part of the psychodynamic psychotherapy session. Again, Madam Dr. Ahalya Raguram, former professor and head of the Department of Clinical Psychology, NIMHANS, Bangalore, is delivering her lecture. So on behalf of Indian Psychiatry Society, I would like to welcome Dr. Ahalya Raguram. Madam, welcome to you. And yeah, I also welcome today's chairperson and my teacher, Professor Dr. Srikala Bharath, who is well known in the area of family therapy, then life skill education, especially. And also she has vast experience of serving in India as well as in Australia, abroad also. I welcome you, madam. On behalf of Indian Psychiatry Society, Karnataka chapter, I welcome you, madam. I also welcome the moderators of this series, Dr. Bheemsain, who is our executive committee member, as well as Dr. Vishwas Yadwad, and all the participants who have joined, postgraduate students, as well as other mental health professionals in various fields. It could be psychologists, social workers, and psychiatrists, and others. So to this webinar series, and also I welcome the host of this series from Icon Laboratories, Mr. Sriram, Mr. Arun, and Bina, and other team members. Welcome you all. So with this, I would like to hand over to the.
Thank you, sir. So as we all know, the chairperson for today's session is Professor Dr. Srikala Bharath. Madam is a former professor of psychiatry at NIMHANS with more than 40 years of experience in clinical psychiatry. And Madam has also been supervisor for psychotherapy training for postgraduates at NIMHANS. I welcome you, Madam, and I request you to introduce our speaker for today's session and go ahead with the scientific session.
Thank you very much, Dr. Tekkalaki. I welcome all the postgraduates who are participants in this. And before I introduce Ahalya, I just wanted to mention that, psychodynamic psychotherapy has had a very, very checkered history from the time of Sigmund Freud. I think, however, I would say that this is one therapy which focuses on why, apart from what and how. It focuses on the developmental perspective as one among its core determinants in the personality development and also the development of psychological symptoms. I think one among today, since Ahalya is going to talk about the practical aspects, one among the things which focuses the psychodynamic psychotherapy practitioners is the efficacy, effectiveness, evidence, RCTs in psychodynamic psychotherapy. However, now in the last 1 to 1.5 decades, there is a very big impetus towards, establishing the evidence-based and efficacy of psychodynamic psychotherapy. And if you look at some of the papers, for example, Dr. Jonathan Shedden in 2010 started the whole process. So I'm happy to talk about the psychodynamic psychotherapy. We can have none better than Dr. Ahalya Raguram. And I have the great pleasure of introducing her. She is the former head of the department and professor and head of the Department of Clinical Psychology in NIMHANS with 30 years of experience. Her clinical teaching and research interests reflect a long-standing and abiding interest in families and interpersonal relationships, as well as family and couple therapy. She has also focused on the development of intervention modules, which are congruent with the cultural beliefs and expectations of families in the Indian context. She has been the coordinator for the training modules on psychotherapies and psychosocial foundations of mental health and psychopathology in the Department of Clinical Psychology. She has been actively involved in various training programs to impart counseling skills for teachers, lay counselors, and other groups. A notable initiative has been the development of a module for armed force personnel to sensitize them to the early manifestations of stress-related reactions as well as the methods to deal with them. She is a recipient of the prestigious Dr. H.N. Murthy Oration Award of the Indian Association of Clinical Psychologists. Beyond her academic field, Ahalya is an ardent wildlife enthusiast with an abiding interest in bird watching. Over to Ahalya. Welcome.
Thank you, Srikala, for those kind words. I think I'm being introduced the second time around, but no matter. So I suppose participants won't forget me after that.
That's a good one.
Anyway, yeah. Let's get on with it. Yeah. Yeah. Okay, so we're all set. Today, what I would be talking about is basically the practice of short-term psychodynamic psychotherapy. In the last presentation, I outlined what are some of the basic underlying concepts that form the foundation for psychodynamic psychotherapy. One of the disadvantages of classical psychoanalytic psychotherapy was the fact that it was a very long-term kind of a process, often running into years, so much so that it had even earned for itself the description of therapy interminable, therapy that sometimes went on almost over the entire lifespan of the individual. In response to some of these criticisms, attempts have been made to develop much shorter forms of psychotherapy, which are, however, rooted in and based upon these fundamental psychodynamic principles. And that is what we would be focusing on today. However, when these short-term approaches in psychodynamic psychotherapy were introduced, that also gave rise to a number of different schools of short-term psychodynamic psychotherapy. To just name a few, you have focal psychotherapy of Malan, you have time-limited therapy of Mann, short-term anxiety-provoking therapy of Sifnios, and intensive short-term dynamic psychotherapy of Davenlu, and several others as well. Those who are interested can, of course, read more about any of these approaches. But what I would focus on is, again, some of the common generic principles and aspects that are associated with short-term psychodynamic psychotherapy. Now, we'll begin with what are some of the basic assumptions that underlie all forms of short-term dynamic therapy. And one of the things is that one of the fundamental assumptions is that whatever people say or do, these actions always have some meaning or purpose underlying them. Many times, these purpose or the meaning may be outside of the conscious awareness of the individual, so much so that they may not really be aware of why they do certain things, or why they say certain things to certain people and so on. And it is just taken at its face value. But the assumption in psychodynamic therapy would be that most of these actions and feelings especially have a definite meaning and a purpose behind it. Therefore, the crucial task in psychodynamic psychotherapy is the exploration of what are these underlying emotions and enabling the expression of these deep underlying emotions. Many times people may have experienced some very intense emotions, as Dr. Srikala mentioned, in the developmental process. They may have had certain experiences which may have given rise to certain intense emotions, but over the course of development, these emotions are often buried deep inside themselves, sometimes in the unconscious part of the mind, or sometimes just at a level where it is not easily accessible in the day-to-day interactions. And this facilitation of the expression of deep of these emotions is a crucial factor for bringing about change. And as I said, this is something that happens when these unconscious or hidden emotions are brought to the surface. Many times, these are also emotions that are avoided. People avoid thinking about it, they may compartmentalize it, so to say, and keep it out of their awareness in their day to day lives and interactions. Of psychodynamic psychotherapy is the fact that one can identify repetitive patterns that occur in an individual's behavior. These patterns are often maladaptive in nature, and as a result of that, the person may be unable to function at their fullest potential, or it may come in the way of their having fulfilling and satisfying interpersonal relationships. These patterns can be identified by exploring the individual's life narratives. That is to say, by tracing and tracking important, significant events that may have occurred in their lives or important and significant relationships that they may have had. However, these repetitive patterns, and this is something that is characteristic of psychodynamic therapy, is the fact that some of these repetitive patterns can also emerge and manifest in the therapeutic relationship itself. And it often then gives clues to the therapists as to what could be the origins or the sources for these repetitive patterns. These fixed behavior patterns can be changed once they have been identified. They can be changed by helping the clients understand their origins. First of all, by making them aware of the fact that these repetitive patterns are occurring, by facilitating insight into their origins. And again, this is a task which is done by also identifying and modifying what are the defense mechanisms that are being used, which perpetuate these repetitive patterns of behavior. Now, coming to the basic nuts and bolts of the therapy process itself, the structure of psychodynamic psychotherapy, one important element, of course, is the fact that that there is a fixed time limited. There is a fixed time limit, in contrast to the long-term therapies. This time limit is generally agreed upon by the client and the therapist in the initial sessions of intake and induction into the therapeutic process prior to actually beginning the whole process of therapy. Typically, the sessions range between about 20 to 30 sessions, and that is what is considered to constitute the upper limit for the short-term psychodynamic therapy. If in case anybody requires sessions beyond that, it would not really then be considered as short-term therapy, but it becomes long-term psychodynamic psychotherapy. The optimum has generally been found to be between 8 to 15 sessions. And if the client has been carefully identified, and if the therapy sessions have progressed as expected, one can expect to see changes between roughly around the 8th to the 15th session. One of the important characteristics of short-term dynamic therapy is the fact that there are clearly specified selection criteria as to who would be suitable for this particular approach. I had mentioned this in the previous presentation also, that not all clients and not all kinds of problems are amenable for the process that is involved in the psychodynamic therapy, and they may require other forms of therapy. So there are clearly specified criteria that are that have been put down, so that the clients who can maximally benefit by this approach can be identified. Goals, there are clearly focused goals in the treatment process. This is again in contrast to the classical psychoanalytic approach, where the goal is fundamentally the reconstruction of the entire personality, which is a very ambitious kind of a goal. That is not attempted at all in short-term psychodynamic therapy. Instead, there are clearly identified goals, again identified in consultation between the client and the therapist. The approach is basically focusing on the here and now. That is to say, focused on the present life and the present functioning of the client. The therapist may begin with the here and now approach, but later, as therapy progresses, might trace it back to early developmental experiences to help the client understand the links. But primarily, the focus is and the importance given is to what is happening currently in the client's life. The role of the therapist is an active one. Again, this is in contrast to the classical analytic approach, wherein the analyst plays a much more passive kind of a role. And the aim is for a rapid restoration of the psychological functioning of the individual. Obviously, when clients seek out therapy, they are in a state where they are either experiencing a lot of emotional distress. Definitely, there is a loss of self-confidence, or a loss of a sense of self-worth and a sense of demoralization. So one of the major aims of this therapy is also to bring about a rapid amelioration of these kind of problems and to restore the psychological functioning at the earliest. Some of the criteria for patient selection, as I mentioned, since this is an approach which emphasizes a great deal on the criteria for patient selection, one of the most important criteria is that there has to be a motivation for change, and along with that, a felt need to get relief. So when a client comes or seeks out therapy in the initial assessment phase or in the intake phase, this is something that the therapist has to carefully evaluate. To what extent does the client feel distress? And along with that, to what extent do they feel the need to find relief from those problems or symptoms? And what are they willing to do in order to obtain that relief and bring about change in themselves and in their lives? This is something that needs to be present if the therapy has to have a successful outcome. Of course, motivation for change is an important factor for most forms of therapy. That is to be understood, but it is a very important factor as far as the short-term dynamic therapy is concerned. Therefore, there also needs to be a willingness to commit to the treatment process. The client needs to have at least average intelligence and associated with that, the ability to express themselves verbally. Again, we know that not all clients are able to express themselves very well in verbal terms. They might perhaps do better with certain other forms of therapy. Okay, so those who have a good capacity to express themselves through the verbal modality and to communicate their issues and problems are good candidates for short-term dynamic therapy. The level of distress has to be somewhat at a moderate level. Very severe levels of emotional distress may not lend themselves for treatment through the short-term dynamic therapy at that point of time, because the intensity of the emotional distress has to be first addressed before the person is able to participate and engage in a meaningful manner in the process of therapy. There has to be some capacity for reflection and introspection. This is an important aspect that is required for short-term dynamic therapy, because much of the therapeutic work would comprise of the therapist helping the client to gain awareness about their impulses or their emotions and so on. But this can be done provided the client is also capable of looking at themselves and introspecting within themselves about their emotions and their ideas and thoughts and so on. There also has to be some capacity to tolerate some degree of anxiety. The therapeutic work, as the therapist helps the client to become aware of certain issues which may have been avoided or suppressed and so on. And if these are brought into the therapeutic sessions for discussion and for facilitating insight and so on, this is likely to generate some degree of anxiety, which the client must have the capacity to tolerate. If this anxiety becomes so high and if it destabilizes the client, then perhaps certain other methods may have to be used in addition to the short-term dynamic therapy. Of course, the ability to form and sustain relationships is crucial, because the entire therapeutic process is based on the relationship between the client and the therapist in dynamic therapy. And it is only through this relationship that many things are brought out into the therapeutic sessions. They are examined and analyzed. And through this process, the client is able to gain a better understanding of their problems. And all this can happen only if the client feels safe in the therapeutic relationship. And therefore, this ability to form and sustain the relationship is an extremely important requirement for short-term dynamic therapy. There has to be evidence of adequate functioning in at least one domain of the person's life. That is to see, when clients seek therapy, it is likely that they are experiencing stress in one or more domains of their lives. And that might be one of the reasons why they are seeking help. But there has to be some evidence that they have adequate functioning in at least one domain, because that can very often be used as one of the resources in the therapeutic process. So at least evidence of one good supportive relationship, or the fact that the client has a job in which they are satisfied and they are happy about, and so on. So in terms of diagnostic categories, who are the kind of patients who can benefit by short-term dynamic therapy? These are generally patients who have depression or generalized anxiety, social anxiety, panic disorder, post-traumatic stress-related problems, grief, those who are struggling with grief, especially long-term grief, people with relationship difficulties, Of course, relationship difficulties can also be addressed if the person is married in the context of couple relationships or in the context of family therapy. But if that is not possible due to the fact that the family is unwilling to participate or the other spouse is unwilling to participate, then yes, these relationship difficulties can also be addressed through the short-term psychodynamic therapy. And of course, those who are experiencing situational stressors. It is not likely to be helpful for patients with high levels of emotional dysregulation. As I said, people with very intense feelings of anxiety or depression and so on, or anger discontrol and so on, may not be really suited for this approach to therapy. When there are threats of self-harm or suicidal attempts, again, this may not be the appropriate form of treatment to attempt. And of course, those with high levels of narcissistic, schizotypal, or antisocial traits, they are unlikely to benefit. These three categories, one of the major problems is because none of these categories would meet the basic requirement of being able to establish a trusting relationship with the therapist, the capacity to establish and sustain the relationship. And because they have difficulties in that domain, they're unlikely to be good candidates for this form of therapy. Now, as in every other form of therapy, this also goes through several phases, and we will just quickly go over that. The first, of course, is to begin with the assessment of the client and the problems. So one of the first things, of course, is to clarify the basic psychiatric history in order to obtain an understanding of, maybe what is the diagnostic issue involved. But along with that, it is extremely important, as I said, to identify if there have been, if there is a history of previous suicide attempts, history of substance abuse, and other such difficulties. But after having clarified the psychiatric history, it is important to explore the onset, the context, and the evolution of the problems. Okay, I'll just come back to that in a minute. Of course, we need to find out in the client's own words, what are their concerns, what are their difficulties which has brought them into therapy, which has in a way motivated them to seek help from a professional. Now, when I say explore the onset, context, and evolution of the problems, this really means going beyond just looking at symptoms. It is here that we really need to understand what's going on in the client's life. What are the person's relationships like? What are the significant events that have happened in his life? And much more than actually just chronicling and obtaining a timeline of these events or relationships and so on, it is important to get an understanding of how do they cope with each of these issues in the past, and what were their emotional reactions in dealing with these problems. Have they had significant relationships and also breakup or ruptures in relationships with significant others in their lives? All these are things that are likely to have a bearing on the concerns and the present problems. It is also extremely important to find out what are the client's beliefs, especially about the causes and nature of the problem. We need to keep in mind that whenever clients approach a therapist for help, they invariably come with their own analysis and understanding of their problems. Sometimes, of course, these days, clients go to the net and then try to look up and read things on the net, and they may come with those ideas. But beyond that, there may be other kinds of beliefs that they may have about what has caused their problem and what exactly is the nature of the problem. It is important to have an understanding of this, because otherwise there can be a mismatch between what the client expects and what the therapist um, attempts to do in the course of therapy. So this also involves probing into the notions and expectations about therapy. What is their understanding about what therapy is, and what do they expect from the whole therapeutic process? One of the things to keep in mind about our clients is also the fact that when you use the word therapy, not many are perhaps very familiar with the term, and may not have much of an understanding of what it really entails. More people, especially these days, are much more familiar about the term counseling. And that is a term that is easily recognized. And more than that, the understanding about counseling and the expectation from the counselor is that they are going to be given some advice, and they are going to be given some solutions to their problems. So these are things that have to be clarified right at the beginning, that the process of therapy is going to be a collaborative one, which involves as much participation by the client in the process. And it is not about finding a magical cure for all their problems. And it is not about the therapist giving them advice and suggestions, but it is basically a process of discovering about themselves, their emotions, and their ways of dealing with their problems. All this is required. This sort of clarification is what constitutes the orientation of the client to the treatment process, in addition to coming to an agreement about what would be the frequency of sessions, what would be the duration, what is likely to be the number of sessions that might be involved, what is the role that they would be expected to play, what can they expect, including the fact that there may be times in the course of therapy where they may feel anxious or even upset about something that happens in therapy. But again, what needs to be clarified is the fact that they have absolute freedom to talk about any of these things in the sessions. And of course, as I've mentioned earlier, critical to establish a trusting therapeutic alliance. The importance of this cannot be overstated. Again, this is something that is a crucial requirement for all forms of therapy, but much more so in the case of the short-term, the dynamic approaches, because we are expecting that the client is going to share emotions or thoughts which they have kept hidden within themselves. Even they may not have acknowledged having such emotions or thoughts. And if we want them to talk about all of these things to a person who is basically a stranger, it is important that this relationship is perceived and experienced as being one which will allow all this kind of information to come out into the open. This obviously then means that the therapist has to have a non-judgmental, accepting attitude towards the therapist, and of course, creating a sense of warmth and safety in the session itself. At the end of the assessment, the information we have should help the therapist to come up with some understanding about why does this client present with these issues and problems at this point in time. So in other words, by putting all this information together and by attempting to answer this particular question, we are more or less coming up with a psychodynamic formulation, which is like a roadmap for the therapist, which gives the therapist some understanding of what could be the origins of the problems, how effectively or ineffectively has the client been dealing with these issues, what are the probable kind of defenses that the client has been using, what are the obstacles that are likely to emerge in the course of therapy, and so on. But we need to keep in mind that these are hypotheses. And as more information emerges during the course of therapy, these hypotheses can always be modified and revised. The important, or the second, or the really the middle phase of the therapy is what is referred to as the working through phase. This really constitutes the longest part of the treatment, the bulk of the treatment, because this is where the problems are really focused on and brought to the surface. So this involves a deeper exploration and analysis. So the client comes initially with some presenting concerns and problems. Once the client and the therapist are comfortable and have established a good relationship, there is a scope then to explore deeper about each of these problems and to analyze the origins of these problems. By gaining a deeper understanding of the problems and how did they originate, the therapist will be enabled to offer some interpretations to the client. These interpretations basically consist of the therapist drawing links or drawing the attention of the client to links that may exist between certain emotions that they experience and certain behaviors, or between certain thoughts that they have and the emotions that follow thereon, or between events that have happened in the earlier phases of their lives, or in relation to certain significant people in their lives, and what may be currently happening in their lives. So in other words, drawing attention to these recurring patterns and linking them to the presenting issues and problems. It is when these unexpressed or avoided emotions and issues are talked about, right? This, in a sense, leaves the client in some ways being vulnerable, because they are exposing the deepest parts of themselves and emotions which they believe are really undesirable or shameful or completely unacceptable and so on. And if they are bringing them out into the open within the therapy sessions, this is what can actually lead to some degree of anxiety or other emotions that may be experienced in the session. But by re-experiencing all these suppressed emotions or avoid the emotions which have been avoided for a long period of time, helps them to actually then process those emotions and come to terms with them, to understand the real meaning and significance of those thoughts or emotions, and then thereby learn to deal with it in more constructive and adaptive ways. In this process, before this can happen, the defenses which prevent these emotions from coming out into the open need to be identified, and the attention of the client needs to be brought, pointed towards the defenses being employed, and they need to feel safe enough to talk about their emotions or their thoughts without the need to use these defenses. And of course, it is in this phase of therapy that the processes of transference and resistance, which are extremely important processes involved in classical psychoanalytic therapy, are also likely to be encountered. I'll just talk a little bit about resistance and transference. Now, in the classical psychoanalytic process, the therapy is not considered to be successful unless there is a transferential relationship that develops between the client and the analyst. And this is something that, however, in short-term psychodynamic therapy, both resistance and transference are not things that are actively encouraged. If at all they do emerge, they are taken note of, and wherever necessary, it is interpreted or analyzed. Now, first of all, resistance. Again, resistance is a process which has now become, in some sense, trans-theoretical. That is to say that although it emerged in the context of psychoanalytic theory and therapy, it is now a process that you can encounter in any form of therapy. The terminology that might be used to describe this phenomenon may differ from school to school, but the basic process is something that most therapists will encounter. So resistance is considered as any process that blocks or impedes the process of therapy. Now, this is in some sense paradoxical because the client has sought treatment in order to overcome certain problems or difficulties in their lives. And yet, in the process of therapy, without their conscious awareness, they are actually resisting the efforts that are being made to help them understand and get to the origins of their problems. Okay, there are different ways in which resistance can manifest itself, and it's important that therapists are able to recognize these, how these can manifest themselves. One of the simplest things that happens is often whenever the therapist talks about things that the client finds a little uncomfortable or does not wish to talk about, you might find that the client, every time that topic comes up, the client might immediately change the subject and start talking about something completely unrelated or a completely new topic altogether. So this can be one of the manifestations. The other manifestation of resistance could be where the client appears to be overtly very cooperative in the process of therapy, in the sense that they might be verbally very expressive and they might talk a lot. But in fact, when the therapist actually analyzes what was said in the session, they might find that it is actually nothing that is that has relevance to their problems and so on. It is just simply that they are talking about many things without actually getting to the core issue. Sometimes the inappropriate use of humor by the client can be an indication of resistance. So, canceling sessions at the last minute after having fixed sessions. So any or all of these can be attempts that emerge in the process of therapy that we can identify as resistant. Now we need to understand, why does resistance occur? Resistance occurs whenever there is anxiety about the material that is likely to come out into the conscious awareness of the person, or material that is going to be brought out and discussed in the therapy sessions. And as a result of this anxiety, because anxiety is an unpleasant state to be in, the individual unknowingly usually tries to resort to various maneuvers that will block this process. Okay. Now, sometimes therapists talk about the fact that, you need to break the resistance in order for the therapy to proceed. Actually, that terminology is not very helpful when you say you have to break the resistance, because it then puts the onus entirely on the client to say that it is the client who is resisting the efforts of the therapist. Instead, if we are to restate and understand the process of resistance as something that the client and therapist both need to collaboratively work on, in terms of understanding what are the issues, what are the emotions that are causing the individual to become anxious. If the discussion shifts to understanding that, then it is likely that the resistance can be lowered. The client gains a better understanding of what is causing anxiety, and with the support and the presence of the therapist, they may be able to talk about it much more openly. Now, transference is basically the displacement of feelings that are experienced in relation to significant others in the past onto the therapist. Okay, and as I said, in psychoanalytic therapy, this was considered to be a prerequisite for the success of the therapeutic process. This is not something that is encouraged actively by the therapist in the short-term dynamic therapy, but it can emerge in the course of therapy. And if it does, the therapist may choose to note it and not do anything about it if it is not interfering too much in the process of treatment, or they might choose to focus on it and help the client to understand where these feelings are coming from. This emotion, this transference, of course, can be both positive as well as a negative one. That is to say, when the client experiences positive feelings towards the therapist, it would be termed as a positive transference, whereas the experience of negative feelings such as anger or feelings of hostility towards the therapist would be considered as negative transference. Now, counter transference is basically the therapist's response, again, which could be either positive or negative, which is the response to the client. And these emerge on the background of the client's, of the therapist's own personal life experiences. And it is for this reason that supervision is extremely important, so that therapists are aware of and understand their own counter-transferential feelings to certain clients that they may have. The last phase is, of course, the termination phase. And this is initiated when the troubling symptoms or the presenting concerns are alleviated, and when the client demonstrates that they are using more adaptive coping styles in dealing with their day-to-day stressors or their relationships and so on. In the process of termination, it is very important to acknowledge the client's awareness and the gains that they have made, and especially to attribute the success to the efforts that they have put in during the process of therapy. This is necessary in order to build up their self-confidence and belief in their own ability to be able to handle problems in the future, and to discuss issues in future functioning, especially in terms of identifying, could there be any high-risk situations or situations that can be extremely demanding, and help the client to be prepared to handle to anticipate and handle those kinds of situations in more adaptive ways. Of course, always to keep the door open in the sense of ensuring that the client is always welcome to reach out and come back to the therapist for booster sessions in future if the need were to arise. Now, so far I've described the overall structure and the processes. I think maybe some of these things will become a little bit more clear if I were to give you one or two examples of clients. So the first one that I would like to talk about is client, a lady whom I had seen when I had just started my career as a therapist. Actually, the presentation was that they were a couple who came for help with their marital issues because they were unable to get along with each other. They were constantly fighting. And that was the reason for them to seek therapy. And therefore, I saw them both. This was a lady who was probably around 35 years old, and the husband was about 40. They didn't have children. And I saw them very diligently, maybe over 8 or 10 sessions, by which time I began to get a sense that things were stagnating, that there was really not much progress or movement, so to say, that was happening in the process of therapy. And they still continued to come week after week. They were very regular in coming for the sessions. They kept coming week after week, but there was really no tangible progress at all. Now, after nearly 10 sessions, the lady called me one day and said that she would like to talk to me alone. Till then, I had usually been seeing them in conjoined sessions. So she requested for a session alone, and I gave her some time to meet me. Now, in that session, she revealed some information which she had never shared with me earlier on. And the information she shared was the fact that she described having a very ambivalent relationship with her mother. She described her mother as being a very efficient person, extremely well organized, meticulous and good in whatever she did, but also very strict as far as she was concerned. That is to say, as far as the client was concerned, especially during her younger days. And she would closely monitor the girl's behavior, not allow her to go out and play too much with her peers. She would be allowed, but there were strict rules governing all of that. So this lady described the fact that on the one hand, she admired the mother, but she was also somewhat scared of her, and at times would feel angry that the mother was not allowing her to do things that she wanted to do. But more than that, she described that one day when she accidentally went to the terrace, she found her mother smoking a cigarette. And for her, when she saw this, it was as though her entire image of the mother shattered. Because this was the mother whom she admired, and she felt that, she was such a perfect individual. And here she was smoking a cigarette. Now, you also need to understand that this was something that happened early in my career, which is at least about 30 years ago. So a woman of the mother's age found smoking a cigarette was a very big deal. And thereafter, she started really hating her mother and completely withdrew. And thereafter, her relationship with the mother became quite a hostile one, almost a hostile relationship with the mother. She later on got married, an arranged marriage. One of her conditions was that the person whom she married should not have any habits. And the person whom she married appeared to be one such individual, except that a few months or probably about a year after getting married, she discovered that her husband was also smoking. He would not really smoke in the house because he knew that she disliked people who smoked. But every time he went out, either to his office or he went out with friends and so on, he would smoke and come back. And this actually became a major issue between the couple. And thereafter, once she discovered this, her behavior was such that she would constantly be preoccupied with this idea as to whether, whenever the husband went out, and especially when he went out alone, as to whether he was smoking, how many would he have smoked. When he came back, she would smell him to see if there was a smell of the cigarette smoke. She would search his pockets to see if there were cigarettes and so on. And although the husband, after a period of time, seeing how distressed and upset she was with this, gave up that also. In spite of that, her doubts and her close scrutiny and monitoring of his clothes and questioning him and all that continued. And that, in fact, became the starting point for many of their subsequent marital issues. And they started, in a sense, quarreling over almost all other issues. Now, when we look at this, there are several things which I understood. One of the things that stood out for me was the fact that this lady chose to share something that was so important for her and which was at the core of all her problems after nearly 10 sessions. So this really suggests that she had difficulties in trust, basically because one can understand that the trust that she had with her mother had been shattered and broken. And thereafter, it became very difficult for her to believe or trust anyone else in her life. And she always took a long time to develop a trusting relationship. But the other reason also, as we talked about it, and when I asked her as to why did she not feel comfortable about sharing this with me earlier itself in all the sessions we had, one of the things she said was, I was afraid that I would be judged. I would be judged as being the daughter of a person who has done something so shameful. And I thought that you would also judge me in the same way, and that you would also feel that I am a person who has come from a bad family and from a bad background. So once it took so many sessions and so much of reassurance for her to feel finally safe enough to share this. And thereafter, she was able to recognize that it was the same kind of feelings that she was displacing onto her husband, with whom she had not shared this information. And she was able to see that the anger and the other emotions and the lack of trust that she had with the mother had all been displaced onto the husband, and that was causing a problem in her relationship with him. And then thereafter, what we were able to do is to see that these were emotions that came from the past because of what for her at that time had been a traumatic event. And that in some ways colored her evaluation of her actual relationship with the husband, who was, later on, she was able to acknowledge that he was actually quite a supportive person He was quite a caring person, and in most other aspects, he was quite open and honest. But it was her difficulties which, in some ways, clouded her perceptions of him and contributed a lot to their relationship difficulties. So this was one of the initial cases. The other one that I want to talk about is really to illustrate the issue of countertransference. And this was something that came up in the context of supervision with the student. Now, when the student was discussing one of her cases with me, again, it seemed like she had not made much of a progress, and she herself was feeling a little upset about that. And she came and said that, "Madam, I think I am stuck. I don't think I'm making any progress at all. And week after week, we are just saying the same things and so on." But it also seemed to me that she seemed very angry with the patient. So I asked her to talk about that. And she acknowledged that she was, in fact, angry with the patient. And she felt angry because her words were that, "I am trying so hard to help her. And in spite of all my efforts, this patient is not showing sufficient improvement at all." And so we talked about that. And why does she feel that, the patient has to improve at a certain rate and according to her expectations as a therapist, and so on. And one of the things that I mentioned to her was that it is not entirely a therapist's responsibility to help the client become better. The client also has to put in their own efforts. And when I just said that to her, I could see such a dramatic change in her expression and attitude. It was almost as if a huge burden had been lifted off her shoulders. And she said, "Oh, you mean that I am not fully responsible for her improvement?" And for her, it was like an aha moment, that it was not entirely her responsibility. In subsequent sessions, we also I talked with her about where did this feeling come up in her that she was responsible for improvement or, for ensuring that the client felt happy and all of that. And it turned out that she shared that she was the eldest sibling in a family. Parents were, they were from a ordinary middle class background. Mother was not very well educated. Father had a modest government job and so on. And she had two younger siblings. Between her and the two younger siblings, there was a bit of an age gap, probably about 5 or 6 years. And because the mother herself did not have much education, as the younger siblings started going to school and so on, the mother insisted that this girl should help them with their studies and so on, which she did. But every time the siblings did not score well or did not do well in their studies, the mother would scold and would be very harsh with this student and would blame her, saying that she had not put in enough effort. So from this, she was able to see that this was the beginning of her sense of being responsible for others' progress or improvement and so on. And this discussion really helped her to get a better perspective of herself and the kind of reactions that she had with regard to some of her clients. So these are just two examples. So, and I would like to conclude with that. But I just want to add a caveat that no matter how much we may talk about psychodynamic therapy or any therapy for that matter, one cannot learn therapy by reading theory. One really has to plunge in, get engaged with a client, and with the guidance and assistance of a supervisor, get to understand the nuances and the processes of therapy. Thank you very much.
Yeah. Thank you, Dr. Ahalya Raguram, for that very, very elegant and very comprehensive, I should say. You have been able to cover all the practical issues of brief dynamic therapy. I see that there are questions, so I think I will open it out. It's already 8:40 now.
Yeah, I know. Sorry,
so
I've exceeded my time.
No, that's all right. I think it was quite interesting. I see that there are questions from the last week.
Oh.
And so somebody has asked about, the physics of the Freudian principles and how it is based on
that question. Dr. Bhatt responded to it last time, so yes. I don't think we should go into it again.
And he has given an article, so I think that should sort of satisfy that person, Benzin.
Yeah.
And so I'm not going to sort of even raise that. And the other person has again asked about schema, the relationship of the short-term therapy to schema, which is much more to do with the other school of therapy. So I'm not sure whether you would like to answer that, because I feel, again, people should raise questions about today's, what has been their, what are their understanding and doubts about practice of brief dynamic therapy, rather than, because the question is, what does short-term therapy does to schema? Can we change the repetitive behaviors or thinking patterns without changing schema?
I just answer that briefly. The thing is, what I have recognized over the years is that many of these therapies actually have many commonalities. They have many more commonalities than there are differences. The thing is that different schools of therapy use different terminologies. But once you cut through the terminology, you'll realize that many of the core concepts are fairly similar to each other.
Yeah.
So even if we are saying, and it is a matter of choice in terms of different schools as to which one do they want to focus on. CBT will obviously focus more on maladaptive thought patterns and schemas and altering that as a way of modifying emotions and behavior. Dynamic therapies might focus more on the emotions as a way of altering thoughts and behavior. Ultimately, in human functioning, all these three are interconnected. It's a matter of deciding what you want to focus on and what you want to begin with.
I think it is mostly all therapies start from the past, come to the present, why
Absolutely.
now, and then how do we plan for the future? I think so, all the threes, and whatever may be the type of therapy.
Yeah.
The other, I think I would skip again another question by the same person. In dream, which ego is dominant, participating or observing, and about conscious, how to conceptualize sleep, deep sleep state, and awareness of absence or absence of conscious awareness. Again, I thought that this must be from the last week's thing.
Not really. This is even outside of last week's presentation, because I know there was a question about the observing ego and the participating ego. You see, these are concepts that are probably more relevant to the practice of classical psychoanalytic therapy. Okay, so I'm not sure how relevant it would be. In any case, the observing ego, because once this question was raised, I also went back and did a bit of reading about it. And basically, what I've understood is that the observing ego is basically the capacity of the ego to observe itself in an objective manner. And this is important in order to facilitate reality orientation. The experiencing ego is that part of the ego which experiences emotions, impulses, and so on, which we may not always be consciously aware of. And it is because of the functioning of the observing ego that in the process of or within the sessions, the impulses and wishes arising from the experiencing ego are modulated and given a reality orientation by the observing ego.
Observing ego. Yeah. I think there are two questions which are actually very relevant to today's session. One is, Dr. Nair has asked, what are some of the indicators that we may be having some counter-transference with our clients, that we should be aware of or look out for?
One, as therapists, we all need to develop ourselves the capacity for reflection. It is, especially in dynamic therapy, it is not a matter of sitting there and advising somebody and giving them suggestions and coming out of it. We need to be constantly aware of and process our own feelings that are evoked during the process of the therapy session. For example, like I gave you this example of the student who felt angry with her client. And the anger was because, in spite of her efforts, the client was not showing sufficient progress or improvement. And we were able to understand what is it that made her feel so angry and upset. Clients are not going to improve however much we try to help them and so on. There has to be a certain dynamic interplay of both client and therapist factors for that to happen. Or it could be a client who makes us feel helpless. And there are many clients who will do that. They will come to you week after week and they will tell you all kinds of problems. And no matter how much you discuss and analyze or interpret, or if in CBT, you help them identify their maladaptive thoughts, whatever it is, they might still say, oh no, but that doesn't work. That is not helpful. So at the end of it, as a therapist, you feel very helpless. What more can I do? So in that sense, we need to understand that the helplessness that you feel is probably the same kind of helplessness that the client is experiencing in their own lives. The fact that they are completely unable to help themselves. And this is a behavior pattern they have of inducing the same feeling in everyone with whom they are in touch with, in their even in their families. So no matter which family or which friend tries to help them, they, in a sense, put them off by responding in this way, by saying that, no, none of that helps, none of that works. So the feeling of helplessness which they induce in others is what they are inducing in you also, right? Or it might be another patient who makes you feel very protective. You want to do more than what is required for the person. So with such clients, you might be willing to accommodate them even at very short notice or give them extra sessions. Sometimes the session time may extend more than what has been agreed upon, and so on. Okay. So what is it about the client that induces this feeling of wanting to protect them? Okay. These are all the kinds of feelings that can be induced in therapists. But the point is that at all times, therapists have to be as reflective about their own feelings and responses as they expect their clients to be. And this is where supervision is important, because it is only when you discuss the cases and the progress and what happens in each of the sessions and your own responses that you can become also more sensitive to your own countertransferential feelings.
I think in practical sense, the therapy should not, the client may walk out, but the therapist has to spend some time going through the session and then reflecting on both the client and also themselves. So I think that's what I would advise, is sort of prescribed to the, upcoming therapists who are the postgraduates. Yeah. The last question is, can you suggest some readings for the beginners for psychodynamic therapy?
There are a number of books available. One good one that I have come across is by Alan Bateman. And I would recommend, I'm sorry, I'm unable to get the exact title, but the author is Alan Bateman, Bateman. And that is like a good beginning for psychodynamic therapy. But I'm sure if you are to search, you'll find any number of books that are available for short-term dynamic therapy. And why I particularly recommend this book is also that at the end, they almost have a description of the therapy process like a manual. So with a transcript, so that will help you to understand the therapy process quite well. I think it is available on the net. The PDF version is there. You should be able to access it.
By, I think, Dr. Kumar, who also asked about the consciousness. He's again asking about the theoretical aspect. Does drive and defense act in pair?
Sorry, I didn't get that.
The drives and the defense, do they act in pair?
Drive?
Do they go and their defenses? So if there is a particular drive, so do they bring up the defenses? Is what is his question.
Depends on the drive. It does. Depends on the nature of the drive, what kind of impulses and drives are there. And as per psychoanalytic understanding, most of them evoke certain kinds of defensive maneuvers from the ego.
Yeah.
Because the understanding is that drives emanate from the id. So it is not that it will be, very automatically and easily fulfilled in the conscious awareness. So it's likely that there will be defensive techniques involved.
Yeah, and it could be any type of defense. It could be a mature one. It could be an immature one. Yeah.
Absolutely.
So
that depends on the person's developmental history. Depending on the kind of experiences, what kind of defenses have they learned to employ over the years?
Yeah. I think because some of these concepts we associate them only with clients, but it applies to each one of us is something which I think most of us have to understand. That all of us have defenses, all of us have drives, and all of us have the structure which is described by Freud. And we are constantly, though we are not aware, we are almost in therapy with ourselves every day. Yeah. And thank you very much for a lovely evening. I think a very, very academic and at the same time very practical oriented evening and a lecture. Thank you, Ahalya. And I thank ICON, Sriram, and the IPS Karnataka chapter, Somu, Vishwas, and Dr. Tekkalaki for making it possible and inviting both Ahalya and myself to be part of this whole process. And I wish all the postgraduates the very best in their career as therapists. Good night.
Thank you, ma'am.
Madam, with your permission, I think there is one more question.
Let me see. That's what it suddenly came up now. I'm just outside NIMHANS. Where are all supervision available for practicing consultants, both in India, outside, inside, online, offline, outside India? So these are the questions by the same person, Suresh. So
these days, fortunately, it is becoming more available. There are some practicing therapists who are willing to offer largely online supervisory sessions. In fact, just today I came across a notice that the Tata Institute of Social Sciences is offering a course for those who wish to become supervisors. Because you need to have developed certain skills for supervision as well, just as much as you need to develop skills for becoming a therapist. And so they have developed a module for those who wish to, learn the skills of supervision. And I mean, they have some criteria. People need to have been in the mental health field for at least about 3 years, practicing therapists and so on. And But there are resources available now, much more than what used to be there earlier.
Thank you, Ahalya, for that. And Vishwas, can we say good night now?
Yes, ma'am. I will go for a vote of thanks. And yeah, thank you very much, ma'am. Thank you very much, Dr. Ahalya Raguram. And you spent 2 days for the session, and you beautifully. I'm using the word beautifully here because your slides are so beautiful, and I became fan of the slides. And along with the insightful and information. And I thank Dr. Srikala for that, ma'am. And she spent her valuable time for chairing the session. And I'm very much happy that I'm reconnecting after so many years. And I thank Dr. Somshekhar Bijjal, IPS-KC Secretary, for making this session and also giving me the responsibility of coordinating all the members. And that in turn, I'm able to reconnect all my teachers again. And I thank the IPS-KC President, Dr. Kiran Kumar, and I thank my colleague and my senior, Dr. Bheemsain Tekkalaki, involving me in this beautiful program. And I thank all the postgraduates and participants and other mental health professionals who were the audience for this session. And I thank the icon, the Sriramji and Beenaji, for facilitating this program. And I thank all the previous speakers and the chairperson, without whom it was not this successful. And I thank everyone. Thank you very much.
Yeah, before you end, I request all the participants here and also spread the message that Indian Psychiatry Society Karnataka chapter is coming up with a new academic journal, Journal of Psychiatry Spectrum. The launch ceremony is scheduled on 8th May 2022 between 11 to 4 p.m. The launching ceremony will be inaugurated by none other than Padma Shri Dr. A.S. Kiran Kumar, former ISRO chairman, who will be delivering a lecture on space, artificial intelligence, and mental health. And also there are many other dignitaries like Dr. Pratima Murthy and Dr. N. Raju from Visakhapatnam is joining. And there will be an interactive workshop on the current status of Mental Health Care Act 2017 in India and state per se by Dr. BMS, Dr. Chandrasekhar and many other colleagues. So I request all of you people who are in Bangalore and in and around Bangalore, also other places also, to come and join us on a historical moment of the Journal of Psychiatry Spectrum launching ceremony, and that will give all of you an opportunity to publish your research work in this thing in our journal. So with this, I thank, and with the permission of the chair, can we end the session?
Yeah, definitely. And thank you very much.
Thank you very much, and good night to everyone.
Yeah, thank you.
Thank you all.
Thank you.